So I'd like to start by just giving some historical perspective on where we've come in the practice of anesthesiology. This will help to motivate why I'm doing what I'm doing in the lab, but also give you a sense of where we are and where we are going as it relates to monitoring patients. So this is a famous painting, and those of you on the East Coast can actually go visit this painting at Massachusetts General Hospital. But it's a famous event in history which took place in 1846. So three men made history this day when William Morton, a dentist, here shown holding the Morton inhaler, anesthetized patient Edward Abbott, while surgeon John Collins Warren removed his neck tumor. And this was the first time in history that an anesthetic was administered to alleviate the pain of surgery. And this happened over 100 years ago. So here, I'll just show you because it's interesting, up-close version of the Morton inhaler. You pour ether in here, and then the patient breathes through this mouthpiece. But how surgery progressed at this time is the patient would just breathe through the mouthpiece. He became unresponsive, and then when they performed the surgery, he didn't respond at all. And they woke Edward up afterwards and said, "Hey, did you feel that?" And he didn't say anything. And so, this was deemed a success. And we now think that people don't experience surgery because they don't respond. But let's fast forward now to the modern and compare this to the modern surgical setting, where our surgical costumes are different. So we're no longer operating black tie like back in the old days, and we've discovered things like sterile techniques, so we use gloves and masks. But we also have advanced monitoring techniques. So we can stick pads and cuffs on people and measure their breathing rate, heart rate, and blood pressure in real time. However, we're still operating under 100-year-old assumptions that patients are not experiencing anything while under anesthesia if they don't respond to this painful stimulation of their procedures. And we're able to monitor this with things like heart rate and blood pressure, but we're still operating under these assumptions. And for the most part, this is true, and anesthesia and surgery are carried out with only benefit to the patient. But the question remains, which is, how do we know patients are unconscious during their procedures? So most anesthesiologists today use one of 5 signs that the patients are experiencing inadequate anesthesia. So they look at the patient if they move, they look if the patient has sweating or tearing, and then with their cardiac monitoring equipment, they look if their patients have increased heart rate or blood pressure with surgical stimulation. And they use these signs along with patients' other vital signs to titrate their level of anesthesia. But with the introduction of anesthesia and advancements in surgical technique, surgeries have gotten more complicated over the years. And now surgeons performing fine manipulations want to make sure that their patients are immobilized to prevent movement. So they're given paralytics for their procedures. And some of the side effects of medications that we give routinely during surgery can cause patients not to sweat or tear during their procedures, or maybe they're draped in such a way that the anesthesiologist can't see these things. And some patients may have cardiac comorbidities that require them to be on beta-adrenergic blockade, so their heart rate and their blood pressure don't respond as expected to anesthetics. So what are we left with? How do we know patients are unconscious? Well, some fraction of anesthesiologists today actually do rely on direct measurements of brain activity to titrate their level of anesthesia using electroencephalography. And so the electrical activity of the patient's brain is monitored using electrodes on the patient's scalp and then sent to one of several commercially available monitors. And here's just an example of some of the monitoring devices that physicians would use in the OR today. So these monitors show physicians the raw EEG traces, so they can look at the raw patterns and identify certain patterns associated with different depths of anesthesia. And they'll give them some process measurements. So if you look on some of these screens, you can see continuous spectrograms. But these companies know that anesthesiologists are busy, right? So they need some kind of summary of what's going on with the patient. And so they summarize this in their proprietary indices. So these are just proprietary combination of various EEG processes, but they give the physician an index between 0 and 100. So 0 indicates the patient is maximally unconscious, and 100 as the patient is maximally conscious. And each one of these monitors has a particular Goldilocks range of indices that they recommend anesthesiologists keep their patients at to ensure they don't experience intraoperative awareness or are too deeply anesthetized. And this works for the most part because brain activity from frontal locations changes as the patient's level of awareness or consciousness changes. For most routinely used anesthetic agents, you see this change in EEG patterns from a high frequency, low amplitude activity to low frequency, high amplitude activity as the patient increases anesthetic depth. And this is much like what we see with the change from awake to sleep states. However, unlike natural sleep, addition of more anesthesia at this low level can drive patients into a more profound unconscious state, where their brain exhibits periods of prolonged depression with interspersed bursts, and this is known as burst depression. And just a side note on this is there's an extensive body of literature showing that prolonged burst depressed periods are correlated with higher incidences of delirium and postoperative cognitive dysfunction, and this is especially true in geriatric patients. But as I said before, anesthesiologists have a lot going on in the operating room, and they can't be expected to be, it's hard to be a specialist at looking at these different kinds of patterns and identifying what's going on with the patient. So how can we summarize this for them? Well, one way, and you probably learned about this morning, is with Fourier analysis. So you heard this morning that you can break up a signal into its various frequency components, and we have a way to look at this. So here you can see these discrete peaks of these different components of the signal. But as you saw this morning, natural biological EEG signals don't have these discrete peaks. But what they have is, the highest activity and power is at the lower frequencies, and then this sort of falls off as a function of frequency. But even something like this is a lot for anesthesiologists to look at. So they summarize this with something called the spectral edge frequency. So this is a frequency with which 95% of the power is below this given frequency. And what's interesting about this is for the common anesthetic agents, like for propofol, I'm showing you here, you look at the spectral edge frequency and the patient's level of awareness, which this is a modified OAS score. So this is just a behavioral assessment of arousability of a patient. 5 indicates the patient is awake and arousable and responds to you. And 0 means that the patient is totally unresponsive. So you see with increasing anesthetic depth, this number decreases nicely. And there's a good relationship here. And additionally, for the BIS monitor, I'll just show you those values. These are generated by the BIS Vista brain monitoring device. And you can see with increasing anesthetic depth, so decreasing responsiveness of the patient, the BIS numbers drop off nicely. So you may say at this point, like, great, we have the spectral edge frequency, we've got these BIS values, and now physicians definitely know their patient's level of awareness. However, this isn't true for all anesthetic agents. So for instance, we take a look at nitrous oxide. This is data from an EEG collected from frontal lobe. And you can see this is when the patient is sedated. This is during loss of response. And at the end, this is after they recover from losing response to anesthesia. And who can tell me what the differences are between these signals? And I'm not really looking for a response because it's a trick question, right? Because there is no obvious difference in these signals visually. And if we look at spectral changes and the summary of these spectral changes with spectral edge frequency and BIS with the varying levels of nitrous oxide, I mean, at 60%, a patient is going to be unresponsive. But you can see in their spectral edge frequency values or their BIS values, these look almost exactly the same numbers as when the patient was given no nitrous oxide. So what do we know about nitrous oxide that might, illuminate why this occurs for us? Well, it's one of the oldest anesthetic agents. It produces dissociative anesthesia, so it's not like going to sleep. It's more like the patient is sort of there, but not really understanding what's going on in their environment. It's an NMDA antagonist, but it's a weak anesthetic agent, so it's typically not used alone. So what happens when it's combined with other agents, particular remifentanil? So Remi is actually a potent short-acting opioid, so this is more given for pain relief than for anesthesia. But it's a mu receptor agonist. It has faster clearance than other opioids, so this has really fast on and offset time. And it was first approved by the FDA for clinical use in 1996. And what's interesting about this, and in particular for what I'm going to talk about today, is that Stanford was the clinical testing site for this. And so this is actually data that was collected, what I'm going to show you today, this is data that was actually collected back in 1996. And you can imagine what electrophysiology equipment looked like back then. And what they actually were doing is trying to determine the CD50 values for anesthesia. And so this is the concentration of Remi that you would give a person, in which 50% of patients don't exhibit the clinical signs of their procedures. And so they actually adjusted this throughout the case. But let's first, before we go into details of this, let's see what Remi does to brain activity. So remifentanil, the effects that it has on the EEG activity look much like that we see with propofol or the halogenated ethers, like sevoflurane or isoflurane. So you see this increase in low frequency, high amplitude activity with administration of remifentanil. And if we look at this in a summary of the spectral edge frequency value, you can see that as we increase concentration of remifentanil here with the black dots, you can see that the spectral edge frequency decreases. And notice the axis here for spectral edge frequency, where the higher numbers on the axis are actually lower frequency ranges. So you can see this is very much like what we saw with propofol. So what happens when we combine these two agents? So for the current study, again, this is a retrospective look at that previous data set. We looked at 32 patients. They required elective abdominal procedures, and they were relatively healthy. And they were given 66% nitrous oxide and oxygen and remifentanil for induction and maintenance of anesthesia. And then patients were tested for loss of response after induction, so when they no longer respond to verbal commands. And then they were tested for recovery of response after the anesthesia was ceased. And then blood samples were taken throughout the procedure to measure the concentration of Remi. And so all patients had intraoperative EEG monitoring, but this was since this was an older EEG device, this particular company had an electrode recording site at AT1, so this is not quite the frontal leads that you're used to looking at. And this is in between the frontal and temporal lobes. And this was on the Aspect A1000 monitor. And I'll show you what this piece of equipment looks like in a minute. But for my analysis, I selected 20-second clips within 2 minutes before and after loss of response, and within 4 minutes before and after recovery of response. And these were just to give me the time to find artifact-free segments. And these segments were also compared to the 20-second segments at the highest blood concentration of Remi, when patients would presumably be at their deepest level of anesthesia. And so this is an example of what that equipment looks like on the cutting edge equipment of 1996. And there's an interesting story from my advisor about how he actually got the data from this original piece of equipment into something that I could analyze on a computer today. But that's for another time. But so for instance, what does this look like? So here's an example of what the EEG data looks like. Again, what you could see from before is after loss of response, you could see this increase in the low frequency activity and reduction in the higher frequency components of the signal. And red and blue lines here are where I selected my 20-second clips for analysis. And throughout my presentation, I've color-coded everything such that red things will indicate when the patient is awake or conscious, and blue things will indicate when the patient is anesthetized or unconscious. And you can see from the spectrogram here that those changes in frequency content are well captured, so that you have increases in low frequency content and decreases in high frequency content after loss of response. And if we follow those things out, just looking at them with the spectrogram, again, I'm sure you guys are used to looking at this, but just to orient you, here's frequency through time centered on loss of response, and then colors indicate power. Warmer colors indicate higher power, and cooler colors indicate lower power. And you can see that this kind of gradual transition in loss of high frequency components and increase in lower frequency components occurs. And if we just look at this in multiple patients, so here I'm showing you an example of 3 patients, loss of response, and again, their recovery of response. And you can see there's some heterogeneity within patients. And that's why some of this spectral analyses can get confusing. So all of them seem to exhibit this increase in low frequency activity, but when you look in the higher frequencies, you have some that don't show changes. And again, with recovery of response, you can see a decrease in the low frequencies, but again, it's harder to tell at the higher frequencies. And if we follow these things out through time, you can see that there's even more heterogeneity when we look at these frequency components through time. But what does this do for the spectral edge frequency and those BIS values? So it turns out the addition of remifentanil to a nitrous oxide anesthetic actually increases the ability for spectral edge frequency to significantly distinguish between these different conscious states. So it decreases before and after loss of response, and then increases as the patient is coming out of anesthesia. But the only thing it doesn't catch is this post-loss of response and high Remi state. And the addition of Remi to nitrous oxide also causes the BIS values to recover. And so if you remember from the figure that I showed you before, the BIS values looked very similar when the patients were at 60% nitrous oxide, but you see that it recovers here. And so it can discriminate between those states. So one thing we can do to better understand how Remi and nitrous oxide are interacting is just by looking at different individual frequency bands, because these agents have different effects on these different bands. So for loss of response, we notice that Remi is predominantly driving the EEG activity. So you have this significant increase in delta activity and then reduction in these higher frequency bands. But for recovery of response, you see that those effects are not as pronounced. So we don't really see much happening. There is some reduction in higher frequency or increases in higher frequency activity upon recovery. Most interesting thing that I found is a significant decrease in theta activity. And I was quite surprised by this. So when I noticed this, I turned to the literature, and it turns out several other labs have reported occurring when they turned off exposure to nitrous oxide. I didn't find anything about this with respect to remifentanil. But nobody really said why this occurs, and I'd be happy to speculate on this later, but my pet hypothesis here, I guess, is that it might be due to the role of nitrous oxide as an NMDA antagonist. And so maybe this is coming from the hippocampus being suppressed for a prolonged period of time. And so you get this big burst of theta after you stop inhibiting it with a nitrous oxide. But again, happy to speculate on that later. And so, for the most part, this combination appears that the addition of remifentanil to nitrous oxide improves the discrimination of these clinically relevant states just using standard spectral techniques. However, we know from these measures, that these measures do not extend to all anesthetic agents in all patient populations. So since the brain exhibits nonlinear behavior at several scales, we explored how well nonlinear measures discriminated between these clinically relevant states. And to do this, we used a standard technique to visualize the phase-space relationships in the EEG signals and created time-delayed embeddings. So to do this, one simply takes multiple points. The number of points that you take in your EEG signal determines the dimensionality of your embedding space. So here I'm using 3 points, so I'm looking at this in 3 dimensions. And then you plot the amplitude at these 3 points in your embedding space. And points are separated by a particular embedding delay, and then you shift these by that same delay, and then you get another point. And you can do this again and again as you go across your signal until you've captured the full signal of interest in your embedding space. And within the space, and actually on Sapien Lab's website, I noticed in discussion for the Lyapunov exponent, they actually describe this well too. So you guys can refer there when you want to try this with your own data sets. So within this space that you finally created from your entire signal, you may notice that the points only explore a limited region, or they may be attracted to just a limited region of space, and so we can refer to them as attractors. And I'm going to call them attractors for the rest of this presentation, but this is what I'm talking about. So what's interesting about this is that attractors plotted from EEG signals, their shape changes with consciousness state. And this has been demonstrated in both humans and animal species. And so here I'm showing you data published from 2014 from our lab, looking at awake rat data. So this is micro EEGs or local field potentials from a rat, and then an unconscious rat. And what you can see is that I'm just showing this in 2 dimensions, but if you look at a video of this rotating, it's a nice spherical ball during the awake state, and it becomes these like flattened ellipsoids during unconscious states. And this happens with both sleep and with anesthesia. So we want to test whether this happens with our unique combination. And it turns out that it does. And you see these nice spherical shapes turn into these flattened ellipsoids with loss of response. And what's even more interesting is that you see this with high fidelity across all of the patients within our sample. So here you notice both the flattening of attractors with loss of response and the inflation of attractors with recovery of response. And again, just note that these are actually 3-dimensional objects, but here I'm just showing them flat in 2D. And so we wanted a way to quantify these things. And we initially capitalized on the 3D shape change that we noticed. So these things, and the difference with the shape change is looking at spheres versus ellipsoids. And so what we did is we just fit the point clouds or attractors with ellipsoids, and we calculated the ratio of the radii. And so if you have a spherical object, the ratio of the radii is closer to 1, whereas if you have an ellipsoidal object, the ratio of the radii is closer to 0 or a very small fraction. And what's cool about this is that it turns out that it significantly is able to discriminate between different brain states, as well as the BIS monitor, which is interesting. But what we've noticed from this first set of experiments is just addition of remifentanil to nitrous oxide causes increases in low frequency activity and decreases in high frequency around loss of response, and the opposite around recovery. And this actually improves the performance of spectral edge frequency and BIS to discriminate between these different states. And I'm introducing a novel measurement of attractors. But we wanted to test whether this occurs in other patient populations, because remifentanil is not and nitrous oxide, are used, but they're usually used in combination. so we worked with a collaborator, Divya Chander, who I think is in the audience today. So, it's great to have her here as well. And she had a great data set of 20 surgical all-comers who were anesthetized with propofol. And propofol is actually one of the most ubiquitously used anesthetics for surgical procedures. So we wanted to explore propofol because it is one of the most widely used. And so here we looked at EEG activity recorded from F7. So this is a more frontally located site. And we can see similar changes, again, the same color coding, and we're looking at a spectrogram and then the changes in attractors. And we can see similar changes that we saw before, where you see similar decreases in higher frequency activity, increases in lower frequency activity, and the shape change in the attractors. Here it's not as obvious, and I can talk about that at the end, why it's not so obvious for this particular data set. But if we look at across all the patients, again, you can see the flattening with loss of response, again, not as evident as previous, but in the recovery, inflation of the attractors upon recovery of anesthesia. And our ellipse radius ratio measurement does indeed capture at a population level the differences between these different things. So, but it's interesting that we've developed this measure to capture the differences, but unfortunately our measure doesn't actually inherently carry any meaning about the underlying activity. It's just like an interesting trick that we found. And so we wanted to compare this to other standard attractor characterization methods to see if we could say something about the underlying EEG complexity, which one of the ways you can do this is with correlation dimension. So correlation dimension is a method to quantify non-integer dimensionality in irregular objects. So here our attractors are basically point clouds, and it's not a solid three-dimensional object, right? It has some holes in it. And so we need a way to sort of define the fraction of dimensionality that it has. So correlation dimension allows us to do that, and it turns out you can say some things about EEG complexity when you use this type of analysis. So we did that, and here, if we're observing a decrease and a flattening of these things, you'd expect a decrease with loss of response and an increase in recovery of response. And that's what we observed both in 3 dimensions and 5 dimensions. And remember, again, with the 5 dimensions, it's just the number of points that you take for your embedding space. And so we also wanted to see whether how well this would track a patient, like across the loss of response period. And so we looked at 20-second sliding windows with 5-second overlap for our analyses. But here I'm just showing you 20-second adjacent windows for the attractors. And you can see as the patient spectral changes, you see this decrease in the high frequency content, and you see the spectral changes you'd expect. But you see our attractors are actually nicely following what's going on with the patient. And these things are consistently flattening with time, and our measures actually capture that. We do see some of these fluctuations right around loss of response, and there's this paradoxical beta rhythm that comes on right as patients are moving from sedated to unconsciousness, and I think that might have something to do with this here, but again, happy to speculate at the end. But for the most part, these all do show decreases. And when we look at the opposite end, when patients are emerging from anesthesia, we see the opposite occur. So here, standard spectral changes that we expect to see around recovery of response. And again, you see the attractor shape change is nicely following the patient's level of awareness. And what's interesting, and as well with our different measures here, and what's interesting is at the end here, within the physician notes, we noted that the patient was kind of getting a little sleepy again here at the end. And you can see that the attractors nicely caught that, and then our measures did as well and decreased. And if we look at this on a population level, just looking at the dynamics, to summarize all these different measures, we can see that our results support current theories on the differences in state changes between induction and emergence. So many people describe the dynamics of loss of response in EEG activity to be more of a gradual process. So you have these kind of like slow, gradual things happening with time. Whereas recovery of response seems to be like an abrupt state change. And we notice this in all of our analyses. And so one last thing I wanted to present today is just using these measures in a patient group that can really benefit from having intraoperative monitoring and the development of novel analyses, and that's with geriatric patients. So most anesthesiologists who use these monitoring devices, when they're given spectrogram throughout the procedure, to titrate their patient's level of anesthetic depth and sort of reach that Goldilocks anesthetic concentration, they look for this dominant frequency in the EEG activity. So this is this nice red band here. It's around the alpha range, but it can vary by patient, but they look for something like this. But if we look for this in a geriatric patient example, you can see that it's just not there. It's not obvious at all. So we want to look at these things. So we want to look at our nonlinear analyses, tracking those changes that we see with the spectral changes. And so here we're looking at this with loss of response and recovery, loss of response and recovery of response. And you can see that this is for the three-dimensional correlation dimension, that the numbers actually decrease throughout the case and then increase abruptly at the end. And this is for the middle-aged patient. So let's see what happens with the geriatric patient. And what's cool here, as you can see, that even though we don't see that dominant frequency in the spectral activity, and it's hard for physicians to judge these sort of subtle changes in the spectral activity otherwise, but you can see within the three-dimensional correlation dimension, you can see really obvious changes happening, especially after loss of response and recovery. And we quantified this actually in a set of patients, geriatric patients on beta-adrenergic blockade. So those patients that are on beta blockers don't have the same kind of cardiac responses to anesthesia, so they're harder to monitor, and they've got this, spectral issues going on, and so they're really hard to monitor patients. But we noticed that with our new ellipse radius ratio measurements that we were able to discriminate between these subtle changes around loss of response. However, correlation dimension didn't capture that, and I suspect that has to do with something about the window that we chose. Because we just chose, again, around ±2 minutes just to keep our analysis standardized. But I think we'd catch it if we looked a little later as patients were a little deeper. So just kind of touching on another interesting thing next. So since I'm returning now to a data set that I described at the beginning of my presentation, where we were looking at the concentration of REMI to determine what would keep patients anesthetized. Because with this data set, we have the unique property that we actually know like specific times during the procedure. So since they were varying the level of remifentanil, during a surgical procedure, they wanted to be absolutely sure that they would catch when these patients were waking up. So they, for those 1 of 5 signs that the patients were actually emerging from anesthesia. And we know the predicted level of remifentanil and the actual level of remifentanil. But this is important because not all anesthesiologists use the EEG to monitor their patients. But we have examples like this, which would suggest that maybe introduction of maybe requiring more anesthesiologists to use the EEG would be important. And so what I'm showing you here is a raw EEG trace, and in the middle I have a sample where the patient moved. So this is when somebody said, okay, the patient moved, so we got to adjust our anesthetic. And these are time locked, even though the axes don't match. But what you can see is that at this movement point, this is when the physician who's not monitoring the brain would make their clinical decision. But any of us can look at this and see, oh, I'm starting to notice like changes going on almost a minute before the physician would do something. And so this could improve, the time scale at which they were adjusting their medications. And I have another example with a blood pressure change. So here there was a significant fluctuation in blood pressure, indicating the patient is, becoming light. And so they need to make a clinical decision here. But here, you can start to see changes up to 2 minutes, or more before that event occurs. So I'm just interested in doing these things and finding a way to quantify how often this occurs.